sure to get the yellow form.
And do you need an CEU or
complete these by the end of the program and turn them into just complete that and hand it to me at the end of the program.
Okay.
Teresa?
And you.
Okay, what is your last name?
And Life's your sponsor tonight.
Okay.
Enjoy your dinner.
Thank you very much.
I'm really glad to see all of you here. One of the things we identified was the need to make physicians in the community aware that this is a problem and what they and you might be able to do about it. As a result of that, this program came about.
You know, so we don't really need to spend a lot of time talking about me. The real story about me is that I'm a community anesthesiologist who spent 1 day a week at a pain clinic, and after a little bit over 20 years of practice, I needed to retire, and due to health reasons. And when I retired, I was trying to figure out what I was going to do, and interestingly, while I thought everybody would be interested in talking to me about anesthesia and anesthesia-related things, the only thing anybody really wanted to talk to me about was pain. And I didn't really understand what was happening. What I essentially did is I said, well, if I can't beat them, join them. And I started going to pain meetings. I started learning about what was going on, and it became very clear to me very early on that there is a very discriminate group of pain experts in this country who get together and they meet and they talk with each other. They come up with guidelines, they publish articles, and so on and so forth. But there is not a good channel of communication to healthcare providers at this level. And I realized that while I might not ever be one of them, nor did I really want to be, I could be someone who brings back information that they discuss in a way that's very easily digestible and meaningful to people. And I hope that that's what you're going to walk away with tonight. So, just out of curiosity, quickly, by a show of hands, physicians in the room? Nurses in the room? Pharmacists? Psychologists? PAs? Any discipline that I have not mentioned? Medical student. We had a medical student this afternoon. Dentist. Okay, dentists. I'm glad you're here, and you'll see why in a minute. It's enough about me. I think the thing you need to know about what we're doing here today is that we're actually making history here today, believe it or not. And I was talking with Bill about this earlier. Whether or not you're aware of it, there were announcements made in Washington last week, a week ago today, by the Obama administration and all of the agencies that are involved with prescription pain medication and regulation, et cetera, et cetera. And basically what they said is that anyone who is involved with writing a prescription for a pain medication is going to have to participate in an educational initiative. And they laid out the contents of that educational initiative. And I have to tell you that the outline we created for this program meets or exceeds what they mentioned last week. So if you are using this exercise as a source of continuing education, save the certificate. There will be a time where somebody's going to ask you to produce it. Think infection control. This is going to become something that people will need to do if they plan to treat people with prescription pain medications. For those of you who can't see the screen, we apologize about that. I encourage you to follow along in the printouts, the handouts that you have in your folder, which is exactly what I'm doing. I don't think we need to spend that much time talking about the layout of this presentation. We're going to talk about the landscape, we're going to talk about a framework, and we're going to talk about some practical steps that people can think about when they're thinking about chronic pain patients and using prescription pain medications specifically opioids, to treat them. And whether or not there are people in the room who don't think opioids are ever appropriate, that's totally okay. Totally okay. So our learning objectives are up there. We're going to deal with current trends and talk about what's going on with respect to abuse and misuse. Talk about some clinical considerations that people need to think about. Really talk about patient safety and outcomes through identification and monitoring. Relevant terminology, which we often at PainEDU find is a little bit of a stumbling block. And then approaches that people can think about with respect to addressing inherent drug-related behavior. From a stakeholder perspective, we're all stakeholders. If you're a patient, if you're a healthcare professional, if you're a law enforcement official, if you're a hospital administrator, if you work in an emergency department or even a clinic, whatever you do, you are in some way, shape, or form a stakeholder, and we all have skin in this game. Just briefly, at a national level, opioid analgesics, and this data goes up to 2007, have surpassed heroin and cocaine in terms of the number of unintentional deaths involving an overdose of medication. More or less, there's one opioid-related death that occurs and takes place in this country every 19 minutes. I think it's also important to mention this, and it's not something I mentioned in the session we did earlier today, is that Florida is a very unique place. There are two layers to the problem, and what I'm going to really be speaking about is the clinical layer, not about the unscrupulous providers and pill mills and those kinds of things. And the reality of it is that when you think of that layer that I'm going to be talking about, it turns out that Florida is not very different than a lot of other places across the country. If you look at this slide, the dark blue areas all have somewhere between 11.5 and 21.1 deaths per every 100,000 people, according to this data that was released in 2007. And I guarantee you it's gone up. There's even a lack of consensus by people about what the definition of overdose is, if you can believe it or not. And I got into this debate a few weeks ago with someone, but my definition of overdose is someone who takes enough medication to have it be considered a quote-unquote poisoning that requires some kind of intervention. But it is worth pointing out that systems like Dawn, which tracks patients who go to emergency departments for certain reasons, their definition of overdose might just be ingesting more than the prescribed amount was. Now, I don't think any one of us would consider that to be an overdose, but it's worth mentioning. If we take a look at this data from the Florida Office of Drug Control in their 2010 annual report, the bottom line is the thing to really look at on this graph. The total number of deaths caused by at least one prescription drug between the period of 2003 and 2009 increased by 102%, from 1,234 deaths to 2,488 deaths. That translates to about more or less 7 Floridians dying every single day. And the impact is huge. And this graph, the unfortunate news for us here is that the county with the highest number of unintentional deaths is Sarasota County, followed by Manatee County, and then right in the middle there is the state average. DeSoto and Charlotte fall below. So we're right in a problem zone here. There are a lot of people who use prescription pain medications as medical use for the uses they were intended. As a matter of fact, there was a survey done by the Substance Abuse and Mental Health Services Administration that actually did a month-long survey, and they identified 9 million medical users of prescription opioids. The scary part is they identified 5.3 million non-medical users. And non-medical use for the purpose of this discussion, and it's a big catchphrase now. Everyone who spoke in Washington last week and on Wednesday when the FDA made their announcement used the term non-medical use. It seems to be clearer and more of an intuitive term. The definition is use of prescription pain relievers without a prescription, a valid prescription, or for a use that's different than what it was intended. So if you use it to help you sleep at night, even though it was originally prescribed for you for your back pain, that's not a medical use. If you use it to deal with a hard day at work, if you use it to deal with the loss of a loved one, that is a non-medical use. And when we look at numbers like this, we're talking about significant numbers. And the scariest thing to me is that in this survey, these 5.3 million non-medical users included people from age 12 and up. Age 12 is another very common mentioned term when we talk about this. And this was up from about 20% from 2002. And just in people ages 12 to 17, the rate of non-medical use increased 17% during the same period. It's a big problem, as Dr. Lepore mentioned. As a class of drug, non-medical use of prescription pain medications continues to have more new users than any other medication class there is. And I think there are a number of reasons, and we probably know what they are. I think most importantly, they mistakenly think these are safe drugs because they were provided by a prescription. And if they're prescribed by a healthcare provider, the perception is they're safe. How could they not be safe? If my grandma can take them, then I could take them. Now, if we look at some other data from this same survey, we can see that 76% of the time, the people who use these prescription medications got it from someone else for who it was prescribed for. So there was a valid prescription, it was prescribed for someone else, 76% of the time it was obtained from that. The other 20% of the time, it was actually prescribed for the person who was using it non-medically. It's simple math, that's 96% of the time. So we're talking about the majority of the time, non-medical users are obtaining the medication through a mechanism where it originally existed in the form of a quote-unquote valid prescription. And that is why the Food and Drug Administration, which was given the authority to get involved back in 2007, is now getting involved. That's exactly why they're getting involved. So I'm going to do a quick little informal poll. Just feel free to yell out your answers. There was an article that was written to the Journal of the American Medical Association. It was actually a letter from the director of the National Institutes of Health, Nora Volkow. She actually did a study where they looked at data from 35,000 retail pharmacies back in 2009 to look at prescription practices and why prescriptions were getting written and by whom. So the question I'm going to pose, and anyone feel free to yell out, is who do you think, what medical discipline do you think was the largest single discipline that prescribed opioids in 2009? Dennis. Anyone else?
Orthopedics.
Orthopedics? Primary care. And that's GPs and family practitioners. 28.8% of the prescriptions for opioids that were written in 2009 were written by GPs and family practitioners. Who's next? That group hasn't been mentioned yet, so it's not dentists. Surgeons. Anyone else? Internists. Internists wrote 14.6 of the prescriptions for opioids in 2009. Now you do the math, you add it together, you're somewhere around 43% of the prescriptions were written by people who were in internal medicine, primary care specialties. Number 3 was dentists. And for age groups 10 to 19 years old, dentists were the largest prescriber of opioid medications in 2009. 31% of all opioid prescriptions written for patients aged 10 to 19 years old in 2009 were written by a dentist. Orthopedic surgeons, by the way, were number 4 with 7.7% of the total prescriptions. It's interesting data. For every 1 overdose death in the United States, there were 9 substance abuse treatment admissions, 35 visits to the emergency department, 161 people with abuse dependence related problems, and 461 non-medical users. The impact is huge. Let's just talk for a second. I think you can agree with most of the implications of this, in addition to babies being born addicted to opioids, is in the elderly. The American Geriatric Society came out with a set of guidelines for management of chronic pain in the elderly patient population. And if anyone in the room has seen it, their recommendation was that opioids are a better first-line treatment for chronic pain in the geriatric patient population than nonsteroidals, because of the risk associated with nonsteroidals. And I'm quoting when I say, except in the rare circumstances where nonsteroidals would be a better choice. Now, to me, that's a very confusing story, because I would worry about people falling, I would be worried about their stability, their gait, their cognition, and all of the other things I would worry about. But those guidelines were very well received. And as early as this January, there were already articles published debating them. So there's a lot of far-reaching public health impact, but I think that this picture really tells 1,000 words. This is an article that was written in the April 9th issue of the New York Times entitled "Dependent on Prescription Drugs Even Before Birth." 1 out of every 10 babies in this state are born with opioids in their bloodstream. That syringe is filled with narcotics, by the way. So where are people getting these medications? We know what clinicians are prescribing them from that survey. Where are the locations? Well, it's not surprising. 30% are coming from primary care practices. The other 39, the other big piece of the pie, the biggest piece of the pie, is emergency departments. Actually, emergency departments are the single largest dispensary, ambulatory dispensary, of opioids in the United States. But if you put them together, you're talking about 69% of, combined as sources, with surgical specialty offices being 10%, medical specialty offices, which would include dentistry, and then hospital outpatients being significantly less. So I think it's worth talking about, are opioids ever indicated? I mean, it seems like there's a lot of problems. Well, I guess it all depends on which side of the fence you're on, because for all the years that I was in clinical practice, I don't know what image fentanyl conjures up in your mind, but I can tell you this, that for all the years I was in practice, fentanyl is actually one of the safest drugs ever developed in the history of the pharmaceutical industry. Now that's a very interesting statement to make, but it all depends on what you consider safe. What that really means is that the effective dose ratio to the lethal dose ratio, where if you were supporting breathing, that it would take to kill someone is 50,000 times the therapeutic dose. you would have to give someone 50,000 times the amount of fentanyl that you would normally give them to kill them, as long as you were supporting their breathing. So it all depends on where you're looking at this from. I think most people would consider the fact that if pain is moderate to severe and that people have been tried on trials of other types of modalities and treatments, and that the pain is having significant impact on function, maybe they're a choice, maybe they're worth a shot. I'll tell you one thing that's really important is that patients need to be agreeable to close monitoring. Now, in the announcements that came out of Washington last week, what they said was that the key and core component of everything the White House and the Food and Drug Administration and the DEA and SAMHSA is going to do is underscore the importance of health professional education and patient education. It is not unreasonable to think about the fact that a patient needs to be agreeable to monitoring. It's done with Coumadin all the time. If you make a decision to use Coumadin to treat someone for whatever reason, you know in your minds that getting them to the right bleeding time is going to take time, it's going to involve adjustment of the doses, and you're going to obviously mention that to the patient. And my 82-year-old Floridian mother actually refused when her primary care doctor wanted to put her on Coumadin for her atrial fib because she didn't want to go through that. So the notion of monitoring patients on prescription pain medications is not something that you might do, it's something you're going to have to do. And I think the way it's going to play out, and when we talk about specifics for the framework, you'll be able to think about it, is that maybe those monitoring limitations are going to be met, and then you'll make a decision, well, that's beyond my level of capability, this is somebody else's job to do. But I'll tell you this, that if the majority of prescriptions are being written between internists and primary care, it's not going to be possible to just say, I'm just not going to do it, because this involves a lot of your patients. So safe and appropriate use, what does that really mean? That's a very common catchphrase. As a matter of fact, there's a safe use initiative that we're going to be doing some work with at the FDA in Washington that actually underscores the whole idea of safe and appropriate use. It means assessing risk, taking into account prior experiences, how comfortable everyone, patient, healthcare provider, family members, caregivers, is with what's being planned. And although somebody like me tends to do what we were taught to do, I think the reality of it is that there is some change that's going to impact you and change your hand a little bit in how you approach patients with chronic pain. From an opioid risk perspective, I think my answer to how we got here is really simple. When Congress declared the year 2000 as the beginning of the decade of pain, and the Joint Commission required that patients have a pain bill of rights, and pain became the fifth vital sign, and healthcare providers were sued for undertreating pain, we got on it. And we started asking everybody, what's your pain? 0 to 10, what's your pain, what's your pain, what's your pain? And then we started to treat the pain. And then people started to get sued for overdose-related deaths. In the medical school I teach at, and I teach bioethics there, I was asked, oddly to me, because we do have a pain clinic, to review the curriculum for the medical school. It's a 4-year medical school. There's 1 day devoted to pain management in 4 years of training at the medical school I teach at. 1 hour is devoted to opioid medication, and most of it looks like my organic chemistry class. So what are the medications that are most likely to be abused or misused? Well, if you talk to the FDA, they think it's the long-acting and extended-release opioids. Do people agree with that? Does anybody think that, by show of hands, that short-acting and immediate release are more of a problem, or are you in line with the FDA? Okay, some people. How many people in the room have heard of REMS? Okay. REM stands for Risk Evaluation and Mitigation Strategy. And what that means is, not unlike thalidomide, the FDA is going to mandate certain terms in which, if you want to prescribe opioids, you will need to fulfill certain components. And what we're doing here tonight is one of those. So, check. PainEDU.org, the website that I and my coworkers work tirelessly to manage, is a non-promotional website. There is going to be an article this week on PainEDU.org about REMS and about the decisions that were made. Take a look. Drugs that give the best high, drugs that are the easiest to get. I was witness to a panel of young college students who were all in recovery from prescription pain medication. And when they were talking about their experiences, they said that the reason they abused prescription pain medications was because it was the single easiest thing they could get their hands on. They said it was easier to get their hands on a prescription pain medication than to bum a cigarette off someone. They're easy to hack. They're the most prescribed, and there was an article that was published earlier this year in Pain, the Journal of Pain, that actually showed that the higher the doses, the more likely there is to be an incidence of abuse and misuse. And another quality of something that's easily abusable is something that's amenable to combining it with other things, because we know that these people aren't dying of overdoses of one single thing, right? We know that there's something else involved in almost every case, whether it's benzodiazepines, whether it's alcohol, whether it's all of those things. I think these are all commonly abused substances. Stimulants are very big in colleges right now, but the reality of this is that people who abuse one thing are likely abusing others. And if you look at what the characteristics are of medications that are most likely to be diverted, and we'll talk about definitions a little bit later, it's the one with the best onset of action, the best intensity of effect, the best reputation out there, and the best value for the buck. I mean, that's really what it's about. These are scientific people, the people who are out there abusing these medications. They put recipes on the internet. They came up with processes called cold water extraction, and it really seems like it's an organic chemistry lab, and they publish these recipes online to each other, and they're a very, very tight community and a very knowledgeable community. Just a minute on pain. Acute pain, I think we probably all know the definition of acute pain. It's sudden onset, it's less than a month generally, it has an identifiable cause, and it's variable intensity, and it requires appropriate treatment. If somebody injures themselves or has surgery, in this country, 98.9% of people who have surgery are exposed to an opioid, and I would venture to say it's probably even higher than that. You will have an opioid. It's when it starts to get beyond that range of acute, maybe that subacute stage where there's some transition. And it's worth mentioning that there's a lot of data that has been published on poorly managed acute pain having a higher likelihood of developing into chronic pain. So if you undertreat someone, you may be setting the stage for them to become a chronic pain sufferer. And that's where the real sticky wicket is, I think, with most of us. Persistent, generally longer than 3 months, although some people do define chronic pain as longer than 1 month. It's usually the result of some identifiable cause, but neuropathic pain seems to be rearing a big head, and a lot of times in people you can't see what's wrong. There's generally some kind of prolonged functional impairment, and it could be physical, it could be psychological, it could be both. And it may be tied to other behaviors. Often it is. I mean, people tell you they can't sleep, they can't eat, they feel depressed, and that the pain is destroying their lives. I certainly, in my exposure to chronic pain patients, when I was in the operating room with them, I was always asking myself the question, what came first, this patient the way they were or the way that they were made to be, especially in those failed back surgery patients, where when I went to put the blood pressure cuff on them or the EKG pads, they would jump 3 inches off the table. There was some hyperactive thing going on, and I don't know whether it was the chicken or the egg, but there were definitely some things going on in the psychological domain. It might have been a creation. Pain is the single most commonly reported symptom in the primary care setting. 57% of American adults seek medical attention for pain-related reasons. At any given time, 1 out of every 3 Americans suffers from some kind of chronic pain. And the challenges at a primary care level, I mean, I don't think we have enough time to talk about them, but time is probably a biggie. How do you, in a primary care setting, do all these things? How do you get educated? How do you spend the time with the patient? How do you wrap your heads around consensus? And how do you deal with the controversy that's out there? You know, it seems almost like caffeine. Every once in a while, I see an article published that says 3 cups of coffee is good for you. And then it seems like 8 months later, I see an article that says 3 cups of coffee is bad for you. So at a primary care level, and this is really what I'm trying to do, the information that is being gleaned by the experts needs to be brought to the people who practice every day in communities like yours. And we can try and hash out some of these things in a framework. Patient selection is an important piece of the process. There's nothing on this slide you don't already know, except for the fact that you need to identify with the patient what the goal and what their expectations of treatment are. If you don't identify the goal, how do you ever know if you reach it? I think the most important thing to elucidate from the patient is the context of how pain is affecting them. Is it preventing them from going to work? Is it preventing them from playing golf? Is it preventing them from being with their family or doing their daily activities? It's way less, in my estimate, important than a 0 to 10 pain rate. And you know, we're brought up with a certain frame of mind. I mean, you know, the way I describe this thought is, how is pain like every other medical condition, and how is it different? It's the same like every other medical condition because people come to healthcare providers and they want them to be the Hippocratic person. They want them to make it better. No, the way it's different is that in pain management, the patient gets to have a say in what a successful treatment outcome is. Now, can you think of another situation where that exists? Diabetes, renal disease, blood pressure, even coronary artery disease, you can measure things. With patients, you have to ask them how we're doing. How are we doing? How has your last month been? How are things working? What's your average pain score? How have you been able to do those kinds of things? It makes it dramatically different, and it makes it important to have an open line of communication. Just a quick word about cancer and non-cancer pain. The fact that they have 2 different names means that they're treated differently. Cancer patients get an emotional check next to them. I don't think anybody thinks about treating cancer patients and worries about abuse, misuse, addiction. Well, we have been working with the people at MD Anderson, and the reality of it is that more people are surviving cancer to become chronic pain patients. And when does the cancer part just get changed to just a chronic pain patient? Guidelines are totally different for management of cancer pain and non-cancer pain. Totally different. So why do some healthcare providers overprescribe? Well, there's this 3D effect, I call it, duped, dated, dishonest. And maybe, you know, there are some people in the state who fall at that 3rd bullet. And then there's this medication mania idea that medications need to be prescribed, that people are walking in, and if they don't walk out with a prescription, then they didn't get what they came for. There's this interesting term called hypertrophied enabling. which refers to the powerful instinct physicians have to do anything medically possible to help their patients. And you know, the interesting thing is that chemical dependency has a huge appetite for hypertrophy enabling. And people who are chemically dependent and addicted, they know how to tap into that with the people who are treating them. And then confrontation phobia. Some people just don't want to be confronted. And I think, based on what we heard this afternoon, some people are scared to be confronted. And that's a pretty scary thing. People underprescribe because of the controversies I mentioned before. Maybe they overestimate the potency and duration. Maybe they're scared that people are trying to scam them. We do hear from people often that I never prescribe opioids. I don't ever think they're a good thing. People get addicted to them. These are just some reasons why people do it. For me, the take-home point is that before pain became the fifth vital sign, opioid risk had an old definition, and it involved constipation, nausea, vomiting, dry mouth, itching, sweating, those kinds of things. And respiratory depression was the big kahuna. When we talked about risk of opioids, especially in the hospital where we're using PCAs and using pain pumps in patients we sent home, we were worried they were going to stop breathing. That was my definition of opioid risk. The new definition of opioid risk in 2011 is unintended deaths. That's it. The other things are there. They're all related to aberrant drug-related behavior. Addiction is the major one. Abuse, misuse, diversion. Everyone who is worried about opioid risk and uses the term opioid risk today is not referring to constipation. They're referring to unintended deaths. That's where everyone's focus is. So, a group of investigators back in 2005, Doug Gourlay and Howard Haidt and other colleagues, published an article that, again, was published in a pain journal. And they entitled it A Universal Precautions Approach to Pain Medicine, a Rational Approach for the Treatment of Chronic Pain. And since I have the time, and I didn't spend that much time talking about me, I'm going to talk about Dr. Haidt for a second. He's a gastroenterologist who was in a major car accident and he broke his back. He ended up in a wheelchair. He ended up on prescription pain medications and became addicted to them. And he worked his way out of the wheelchair into a brace. And then he worked his way out of the brace out into recovery. And now he's a pain medication expert. He's a very amazing man. I believe you have at least the abstract of the article. Oh, you have the whole article, so take a look at it. When they wrote this article, what they were thinking is what we thought back in the mid-'80s with respect to HIV. Don't assume that everybody is an abuser or misuser or is going to be addicted, but assume that everybody could potentially become an abuser or a misuser or display some other type of aberrant drug-related behavior. So there are 10 components of a universal precautions approach. I'm going to go through. None of them are radical. None of them require a whole lot of thought. But the point of the matter is to put them together and use them as a philosophy and an approach. And if you think about this REMS term that I talked about, the REMS term is going to require that this take place, all of this. And in order for you to survive an audit, if the DEA ever came to your door because you were prescribing chronic opioid treatment for someone, they will want to see that you went through these 10 steps. So first, make a diagnosis with appropriate differential. It's important. You need to make sure you identify why you're prescribing the opioid. Patient complains of back pain is not going to carry. You need to know what the back pain is coming from, or at least have a presumptive reason as to why. The next thing, and I'll spend a couple of minutes talking about this, is a psychological assessment, including a risk assessment of addictive disorders. Now, when I say this to people, they look at me, but the reality of it is you're going to see this in a couple of slides. What if I told you that researchers got together and created a psychometric tool that could predict the likelihood of aberrant drug-related behavior before the prescription was ever written? And it would give you a number that would assess risk and allow you to categorize the patient in a low, moderate, or high risk category. That tool exists. You're going to need to use it as part of a universal precautions approach. Asking about a personal and family history of substance abuse. Personal, obviously, you need to ask. But with respect to family history, there are published data about the fact that people who have family members who have addictive disorders have a higher incidence of addictive disorders themselves. So let's just briefly talk about the tools. You have information on the tools in your handouts. Some of the tools are available on painedu.org. You can get them. Paine.edu costs nothing to anybody. Anything that exists on Paine.edu is free. The opioid risk assessment tools that I'm going to talk about are the opioid risk tool, developed by a very respected pain clinician in Utah, which is one of the worst states with the highest incidences of prescription opioid-related deaths. The opioid risk tool is a brief screening tool. It's simple, it's clinician administered, it's not validated, but it's really short and really easy to do. The SOAP tool is the tool that I was referring to. It's the screener and opioid assessment for patients with pain, or the SOAP. It exists in 3 different formats, 5, 14, and 24 ID versions. But the difference is it doesn't add any extra work for you because it's a self-report tool. The patient answers the questions. And in many cases, they don't know what the right answers are to the questions. It takes about a minute to score, and then it actually gives you a number, which you can document in your medical record, not to not prescribe an opioid, but to show that you assess risk. And the reason you were assessing risk is to determine how you were going to monitor the patient, not whether or not opioids were a right decision. By now, you should have already come to the decision that opioids would be a good component of therapy, and just like non-steroidals, ask the patient about risk and start to go down that road. A tool like this was designed for that. Now, that tool, the SOAP, was only designed to be given at the time the decision was made to prescribe, to sort of create a baseline. The current opioid misuse measure, developed by the same investigators, is a validated tool that is intended to pick up where the SOAP leaves off. You re-administer it to patients every time you see them, and it, again, assesses risk in an easy way. It's a patient self-report, and you document the fact that you assessed risk. The pain assessment documentation tool is another tool that was developed to follow patients along the course of therapy, and it's much more like a progress note. It's a few pages long, it's very comprehensive, and at the end, it asks you as a healthcare professional to basically give your overall assessment of what you think the risk category of the patient is. So it's a little bit less scientific, there's no score involved, but it is a good tool to make as a documentation piece. So something needs to be done. Informed consent to me, and what seems to be a very hot topic now, treatment agreements, they sort of go together to me. And the reason they go together is because in ethics I do a lot of teaching about this topic, and I think a lot of people think that informed consent is the same thing as a treatment agreement. It's not. Informed consent is about risks and benefits and making sure that the patient understands, and you've communicated to the patient what you're thinking are the risks and benefits, and they acknowledge that. The treatment agreement, even though you will hear people refer to it as a contract, and it does have some negative connotations out there, is more a document that delineates responsibilities of all of the people involved. Healthcare providers, patients, everybody understands their responsibilities. Everybody knows what do's and don'ts are. Everybody knows what the goals of treatments are. And everybody also knows that it's dynamic and it might change when you come back for your next visit. We need to revisit it. It's often written, and the reason it's often written is because it's easier to document, but it can be verbal. It just needs to exist, and it needs to be documented that it exists. But if you think about it, if a treatment agreement has these core components, you're doing a pretty good job, but there's no rocket science here. Under obligations, I think from a healthcare provider perspective, it's if you have breakthrough pain, here's what I want you to do. It may involve calling me, it may involve this. This is what you do. Here's what I need you to do. You need to agree to how I'm going to monitor you and how I'm going to measure compliance. And if I ever ask you to pee in a cup, you treat it just like I was putting you on Coumadin and taking a bleeding time. The other thing that they stress in the universal precautions approach is to sort of measure the pain assessment before and after you start treatment, and consider the use of an opioid in a chronic pain patient if you decide it's a valuable component as a trial of therapy. It's nothing more than we're going to give this a try. And it needs to include function. It is not just about 0 to 10. If you don't ask about the context, you're missing everything. There are patients out there who can't get off the sofa with a pain score of 6, and there are patients who go to work every day with a pain score of 8 or 9. You have to understand how it's affecting the patient's life and document that. Considering a trial of opioid therapy plus or minus other adjunctive medications, you know, as a first line of treatment. You know, I talked about the American Geriatric Society guidelines. I think that in most situations, as part of a multifaceted plan, you certainly need to consider things like drug-drug interactions, whether or not the patient ever has a glass of wine or alcohol, because that can affect the pharmacokinetics and the pharmacodynamics of medications, certainly in the extended release formulations. And a lot of pharmaceutical manufacturers have got dinged with respect to that. It's also important to reassess pain score and function at regular intervals. You're touching base about how the person is doing. No progress after a certain amount of time means that maybe the treatment plan you've selected is not the best one, and you've got to find something that works better. And I mentioned this before, regularly assess the forays of pain as part of that pain assessment. Analgesia, activity, adverse effects, and aberrant drug-related behavior. Aberrant drug-related behavior by using a tool that allows you to document something that you did to assess risk, talking to family members, caregivers, the patient, trying to figure out what's going on. And periodically review the pain diagnosis, and I was fascinated by the fact that they included this as part of the universal precautions approach, but they actually rightly mention the fact that pain may be a dynamic thing. And certainly how people deal with their pain is dynamic. I know that when I am in a bad mood, or even if I have a cold, things that bother me more. So it's important to consider the fact that social changes happen, stress happens, structural changes happen. Even if you're treating the person for back pain and you know what the diagnosis is, structural changes happen. And even pain sources can change. Documentation is the last point. It's medical legally indicated. It's to everyone's best interest. It's a regulatory safeguard. And I think, you know, we all know, I've certainly heard it in my malpractice reduction courses, that if you don't document it, it didn't happen. Not documenting an assessment of opioid risk would be akin to putting someone on Coumadin who has a bleeding diathesis. Just so you know how the regulatory agencies are looking at this. Patient education. When patient education was mentioned last week in Washington, it was mentioned in the context of the healthcare professionals being tasked with the job of educating the patients, as if you didn't need something else to do. There's a lot of talk these days about shared decision-making in the medical home, and that patient-centered care might be as important as the treatment that's selected. I think that if you follow the practices of the universal precautions approach, you're probably talking to the patients about most of these things, especially if they have informed consent. And there's obviously a lot of challenges, but the benefits are definitely there. With respect to monitoring patients, we talked about reassessment, we talked about tools. The reality of it is that there are other things you can do. You can ask patients to bring their vials with them and tell them that their pills will be counted. You can tell them that you may need to do periodic urine drug screens if they fall within a certain risk category. And when you look at these tools that are available to you, there are guides if the patient falls out in a certain range about how to monitor these patients. If urine drug screen falls into that patient's risk assessment, but it falls outside of what your capabilities are, that's a good time to say it's time for me to refer this patient to someone else for co-management because I'm not set up to do that. There's nothing wrong with that. So knowing the differential, knowing how to approach the patient and have an exit strategy. If it's a trial of therapy, there has to be an exit strategy there. Discussing concerns with patients, talking to them and educating them about the risks of addiction and long-term plan and safe medicine practices such as disposal, storage. These were all on the list that the FDA mentioned last week on Wednesday at the teleconference that I participated in. These are all things that need to be talked about. I don't think I've said this yet, if there's anything we walk away from today, it's with the phrase, here's what I want you to do with the unused portion of your pain medication. I don't know anyone who's ever said that to someone. Think about it. When I prescribe an antibiotic, I say to people, you gotta finish the antibiotic. If it's 14 days, you gotta take it until it's over. You're lucky enough to have ways that are sanctioned for disposal. A lot of other states don't. As a matter of fact, there's conflicting information. Even in New York State, we have a website called donotflush.gov. And then we have other medication guides that are distributed by manufacturers that actually say the safest way to dispose of a medication is to flush it down the toilet. These are important topics for safe medicine practices. And it's worth mentioning the fact that there have been a number of studies of measuring the incidence of addiction in chronic pain patients in a primary care setting. It's only about 3.9%. That means that 96.1% of the time, it's not an issue. However, in that 3.1% of the time, the patient might have a very high risk of dying, which is why it's getting so much attention. We'll close with some terminology. And I think this is important, and this is probably one of the most important. I hear these terms interchanged all the time. Misuse is use of a medication for a medical purpose, other than as directed or as indicated, whether willful or unintentional, and whether or not harm results or not. That's misuse. And when the FDA came out with a ruling on the amount of acetaminophen in combination products about a month and a half ago, I was surprised that Jay Leno actually incorporated it into his monologue. And he said the FDA made an announcement today reducing the amount of pain medication in Percocet. And I heard that one of the drug companies is already developing a new drug, and it's called 2 Percocets. That's misuse. My wife never opens a bottle of Advil and takes only 2. Abuse is intentional self-administration of a medication for a non-medical purpose, such as altering one's state of consciousness, for example, getting high. So misuse, I think, is pretty common. If somebody's taking a pain medication that was prescribed for them and it's not working, they'll take another one. I think we do that all the time with other things. I know when I'm getting a cold, I take an extra vitamin C, and I don't even know if there's any value in it, but people are used to doing that. People tell me that for menstrual cramps, they'll triple on Aleve or Advil doses. That's misuse. So dependence and tolerance, they are both states of adaptation. The difference between dependence and tolerance is that with dependence, if you discontinue it, the patient's going to withdraw. That's dependence. Tolerance is actually a normal physiologic situation where the metabolic pathway ramps up and deals with the load that you're placing on it. I would argue that in almost every situation, tolerance is a normal phenomenon. Dependence is probably a normal phenomenon too. I mean, we don't think strangely of people who are on prednisone becoming dependent to steroids and needing to be weaned off. That's a great example of dependence. Addiction, on the other hand, is and this is not my definition, but I think it's a good one, it's a primary chronic neurobiologic disease with genetic, psychosocial, and other environmental factors that influence its development and manifestations. And the hallmark characteristic of it, besides all the things that we think of, is that people continue to use whatever the substance is, despite the fact that it's doing them harm. Now, pseudo-addiction is one of these terms that is thrown about every once in a while, and I think for the sake of being complete, we cover it. It's a syndrome of abnormal behavior resulting from the undertreatment of pain, where the patient's stage gets set that they think they could do better, but the amount you're giving them is not good enough. So they get drug-seeking behavior, and they think that if you give me more, I'll do better. It's almost like they're trying to misuse the drug because they feel twinges of being better, but not as far as they want to go, or it doesn't get them functionally to where they want to be. And it really exists. Diversion is the intentional removal of medication from legitimate distribution and dispensing channels, and that could be anything. JetBlue. Protecting your practice. So, think universal precautions. I hope I was accurate in my description, that there was really nothing in those 10 items that is really rocket science-like, or doesn't make sense, or that's so overly complicated that it's not possible to do. You need to definitely know your treatment population and the geographic risk. Anything that could be considered opioid-sparing, why wouldn't it be used? I mean, opioid-sparing is a positive term. It's a good thing. Collaborate with colleagues regularly. There is a dramatic disconnect between the ways in which people within a community like yours communicate with each other. I think that PJ is actually going to be talking about some of them. But I can tell you that in my community, when somebody refers a patient to the pain clinic, they're trying to dump that patient and never see that patient again, but still take primary care of that patient for everything except the pain management. That's not collaboration. And it's also not going to work. I had a nurse in my hospital who developed reflex sympathetic dystrophy postoperatively, and I could not get her into the Stony Brook Pain Clinic for 12 weeks. Now, 12 weeks is a ridiculous amount of time to wait. There are only 7,000 pain experts, true pain experts in the United States. Try and, you know, I'm not preaching to you. I think you all know what sensible is, but opening the door to this doctor-patient relationship and making it part of communication with patients, as well as the family and friends of the patient, can only help. And using psychosocial indicators of good functioning is a key piece of the puzzle as well. Documentation is critical. I'll leave you with this. Fibromyalgia has been getting a lot of airtime lately. And sometimes good, sometimes bad. Even the doctor who coined the condition's name is having second thoughts about it. Some people don't even believe that it really exists. The incidence of patients who suffer from fibromyalgia that have depression is 1 out of every 2. I would venture to say that the incidence of depression and other kinds of psychological conditions in people who suffer from chronic pain, it may not be 1 out of 2, but the potential is there for there to be some comorbid thing that's going on. What they really need is they need the motivation factor, because I think that if you have that motivation, somehow or other, you just end up getting better. And I think it's the ability to do what you want to do in that context that allows you to do it. But we haven't figured out how to bottle that yet. So, thank you very much.